and thank you for this opportunity to present existence and determinants of task shifting practices among doctors and nurses at Kenyatta National Hospital. I'm sure everybody is awake when we talk about task shifting, and I'm happy that we shall discuss this. So this is the outline that I have, and those are the acronyms that I'm going to use. Most of them are familiar. I'd like to draw your attention to TS, which will be standing for task shifting, and PT is patient. So introduction, WHO has defined task shifting, and task shifting has been there since time immemorial. It's not a new thing. It has been there since 19th century, and like one of our speakers did say, it will continue to be there. It may not be officially running, but it will be there because of the situations and the conditions that we work in the healthcare, especially in the low and middle-income countries. So there has been this acute healthcare shortage, and it has been giving us a setback in universal health coverage. And one of our speakers this morning asked, where is it that we are having universal health coverage? Yet in our Agenda 4, we are talking about universal health coverage. As much as universal health coverage is a long journey, it must start with one step, and we move to the second one and the third one as we move forward as a country. Because every citizen in this nation needs basic health care. And WHO had said, one of the reasons why WHO had recommended task shifting is because of the staff shortage that we have been having in the third world. There has also, I would like to say, compromised succession planning, which keeps to loss of intellectual capital. And therefore, WHO was seeing, like, if we do task shifting, we are going to mainstream succession planning in this nation and other nations. So what was the problem of this research? We are saying that we are having, we've been rated among the worst 57 countries that are doing very poorly in terms of crisis in healthcare, human resource in healthcare. And the reasons are several. We have issues of planning our health capital. We have problems of our population. I think now we are heading, is it to 48 million? And the healthcare numbers are dwindling. At the same time, disease trends are also sending us on a crisis. There's the healthcare funding. We did the recommendation many years ago of 15%, but look at this year, for example, if I can refer to this, we did almost 5 point something, heading to 6. Therefore, we are far behind where funding should be. Then the issue of brain drain. We used to talk about it a lot. We've gone silent about it. And therefore, we are training our staff, but we are giving them out to the Western world. And therefore, the numbers keep going down. Something about brain drain, we even baptized it. We are not calling it brain drain anymore. And therefore, we are not addressing it as a problem. We are kind of accepting it and saying those who go to work out there, they can come and invest at home. We need to address it. And then the healthcare production issues. Our production has gone low. And that came out from the intra-health speaker who did speak this morning. And therefore, WHO looked at task shifting and task sharing to improve healthcare indicators by utilizing the healthcare, the human resource that was available in the healthcare. And therefore, it had been implied that implementation of task shifting would go a long way even to address our issues, including Kenyatta National Hospital. So as a nation, we didn't have a policy in this, but we wanted to look at, is it existing in Kenyatta National Hospital? If it is existing, then what is it? how are they, what implications does it have? And that's why we did the 5 study objectives. We wanted to know whether people had the knowledge, whether it was actually existing, the tasks that were being shifted and to who, and also we wanted to look at the facilitators and barriers and the experiences that the nurses and the doctors were having in regards to task shifting. So literature review a little bit. I've already talked about staff shortage, and then there's the bit about skewed urban-rural distribution. Now, when we're talking about universal healthcare, this must come out strongly, especially in a conference like ECSACON. We must address urban-rural distribution in this nation and elsewhere if we are going to achieve universal health coverage. And therefore, task shifting is about redistribution of tasks between different cadres. It may be one senior nurse giving some of her work to a lower cadre of a nurse, or it can be across cadres between a doctor and a nurse. And I know I'm breaking and opening a can of worms, but I think we need to converse around this. We cannot hide our heads in the sand and do business as usual. We need to do business unusual for us to get to some place. So evidence shows that task shifting helps to mitigate staff shortage. By implications of expanding the pool, it also creates linkages between different levels of healthcare, from the community to level 2, 3, 4, 5, and therefore linkages are strengthened. It also creates new opportunities, even in succession planning, and also creating employment for new cadres of staff. It also improves universal healthcare, especially when you're looking at access and quality. It has been evidentially shown that it improves that kind of care. So task shifting reorganizes the workforce, and where it has been practiced, even in this continent, it has helped in coaching, reducing workloads, reducing burnout, especially addressing the burnout phenomena that has been rampant among the healthcare givers, and more so among nurses. It also has been shown to reduce patient complaints. And therefore, looking at the proponents and the opponents' arguments around task shifting, what is it that we can draw from this, as much as it has been kinda illegalized? So what was the methodology? It was a cross-sectional study, and we used the actual tasks that were done by the person. We compared it with the job description and also the scope of practice. That is how we came to decide whether the tasks were being shifted or not. There were the quantitative aspects of analysis were done through SPSS version 22. Quantitative, we transcribed, we coded, and we were able to put it in thematic areas so that we were able to analyze. Kenyatta National Hospital, NERC, is the one that helped to do the ethical approval. And this was the sampling areas, through proportionate sampling. So you can see the age group, the largest, the biggest proportion was between 25 and 29, and you can see they are running up to year 64. It means there are people who are still working on contractual basis beyond 60. So our workforce can still help to meet UHC even beyond 60. And these were the qualifications. Majority were diploma holders. And did people have the scope of practice? The majority had. But we still had a few who did not know what their scope of practice was, and they said they are not being given any. In terms of knowledge, you can see minimal knowledge around task shifting. And in regards to whether they were trained on the task before it was given unto them, you can see what people are saying. It is illegal to give somebody a task if they are not qualified to do it, and if we don't either coach, mentor, or do on-job training. Healthcare is not anything we can experiment with. When it comes to reasons for task shifting, you can see the variety of reasons, and I'm happy it is visible. Owing to the time factor, please, some of them you just read them, but just look at the reasons why people were task shifting. There were factors that were facilitating task shifting, and some of them were the benefits, then the workload, then whether they were able to adhere to the rules. For the few that knew the rules, whether they were adhering to them or not, teamwork, the staffing ratios, knowledge, and all that were some of the facilitators that were influencing task shifting on the positive. Now, what were the hindrances? Some of them were bias, nepotism, racism, tribalism, favorism. Healthcare workers, professionals, this thing has been rampant in this country, the nepotism, the bias thing. And for us as professionals, let us stand out to fight this thing. Tribalism can be bad, and we have seen it during elections. We need to fight it tooth and nail until we get to our best. I will not comment on the rest because I know you have read through them. So what is the conclusion? Knowledge on task shifting was quite low. Guidelines or policy, there was none. It was rampantly being practiced, but without any harmony. Because if something doesn't have a policy, if something doesn't have a guideline, if you don't have champions that are leading something, you're likely to have haphazardness. Types of tasks shifted were isolated, and I cannot enumerate them because there were many. It's quite a large study, and therefore they cannot be enumerated here. We also saw the factors that were influencing task shifting. And the task shifting was perceived to be beneficial to patients, to staff, to the healthcare system. But like I said from the beginning, it has become a can of worms. And that's why the world over we are having proponents and opponents. So as a recommendation, if it was the way to go, then guidelines would be required. Training, mentorship, coaching, on-job training needs to be embraced. And then the other way would have been to have champions to drive task shifting. Thank you very much.